Welcome to Robert Wood Johnson University Hospital's Health Talk. I'm Dr. Douglas Oshinsky of Robert Wood Johnson Physician Enterprises, Warren Internal Medicine. Eating disorders affect 20 million women and 10 million men at some point in their lives. These can include disorders such as anorexia, bulimia, and binge eating. If not treated, eating disorders can cause serious health problems, including death. On today's show, we'll learn more about the warning signs and symptoms of eating disorders and how to get help from Dr. Darlene Osipuk, the co-medical director of Robert Wood Johnson University Hospital Somerset's Eating Disorders Program, Kelly Kohler, a therapist with the program, and Christine DeSouza, a registered dietitian. Welcome to the show. Thank you all for coming here.
Thank you.
As the audience notes here, we have a team here, and the whole eating disorders works as a team. So why don't each one of you introduce yourself, who you are, explain a little bit about yourself and what you do as part of the eating disorder program. Okay. We'll start with you, Doctor.
I'm co-medical director of the Somerset Eating Disorder Program, and I've had extensive experience treating eating disorders. I started out of my residency program learning about eating disorders, setting up an eating disorder program in the 80s, and then progressing toward inpatient eating disorder treatment centers, residential centers, as well as partial programs. And the program at Robert Wood Johnson Somerset Hospital is truly an exciting one. We're one of the only 2 eating disorder inpatient medical treatment centers in the state of New Jersey. And given the St. Barnabas Robert Wood Johnson healthcare system, there is an incredible opportunity to get out there in the programs and educate families, practitioners, school systems about the seriousness of these eating disorders, the identifying symptoms that emerge for these individuals, and the treatment interventions, possible. Exciting about the St. Barnabas Somerset Eating Disorder Program is the development of more of an adolescent treatment program that we're working on, and really very committed to developing in our eating disorder treatment program.
Thank you. Kathy, a little bit about yourself.
Sure. So I am a therapist on the eating disorder unit at Robert Wood Johnson in Somerville, and I provide individual therapy, group therapy, and family therapy to our patients.
And I'm Christine. I'm the nutrition coordinator at the Eating Disorders Program. I've been there for about 20 years now. And my role is to help patients get nourished and dispel some food myths and work with the team.
So let's start off with food myths and things like that. The big ones we have to be concerned about are anorexia, bulimia, binge eating, but there's also variations of all of them. Let's first start out just with the definitions of anorexia, bulimia, binge eating.
Well, I think the definition of anorexia nervosa is a profound disturbance of body image, a relentless, compulsive drive for the pursuit of thinness, bolstered by a kind of underlining drive for perfectionism. And that's part of the start of how that unfolds. There's a significant denial of the seriousness of the illness that as it unfolds. And it evolves over a course of time. So families, teachers, pediatricians, adolescent medicine practitioners, track over some time evolving signs and symptoms. And it's a slow progression and evolving. And the warning signs are, it starts off rather benign. Diet, a desire to lose a few pounds, train for the next season in sports and begin to get healthy. And then it emerges and evolves from there slowly but insidiously over a period of time. And that's why sometimes it takes time to identify, these warning signals and signs. These young adults are accomplished, intelligent, competitive, talented, and so they've got a background that is not necessarily identified as a young adult, struggling or in trouble. They've got their A's, they're athletes on their teams, but it begins to become more rigid, less spontaneous. They become more restrictive. They're really compulsively driven. Their exercise routines now become mandates. If they can't exercise, it's like a really bad day. And I mean a bad day. The whole day is done. Families are tortured. Meals become nightmares. There's hiding food. There's excuses. There's layers that start to emerge for these young adults. So you're not really seeing how undernourished they are, their weight loss. And until they're taken to their adolescent medicine specialist or their pediatricians for a yearly physical, and it's like, wow, what happened? Your weight has gone down 15, 20 pounds since last year. And then the bells start ringing, But at that point, this is entrenched. This is an obsessive preoccupation. They become walking calculators for calories, obsessively focused about food, calories, weight, weighing themselves, reading food labels, really driven by needing to lose more weight, and there's not a problem. They're still getting their A's, they're on their teams, but then now the coaches are starting to get concerned. Teachers are becoming concerned. And most importantly, peers are now really kind of getting worried about their friends and starting to go to teachers, starting to go to the guidance counselors, starting to call the parents. Now, when you get peers starting to kind of report in about their friends, that's a real problem because they're sitting at the lunchroom, they're eating their French fries, they're seeing them with salads, they're seeing them toss their lunches or eating merely, a bit of an apple, during their snack time for their sport practices. And it just continues to tumble. Worse is when they show up in the ER because they're lightheaded, they're dizzy, they're orthostatic, they're dehydrated.
At that point, though, we're pretty much past what we should be.
Yes, absolutely.
So again, we're looking at not only the adolescents, but also the younger adults also. And
yes.
Unfortunately, due to media inundation that everyone has to be thin, that adds a lot to the perception, their poor body perception of themselves.
Right. Yeah. It raises the threshold of where these disorders are identified, and at that point, that threshold being so higher in terms of our expectations, our cultural kind of mandates, even our competitive natures, it's really identified later in the game, which makes it even more intensive, the interventions and the therapies and the medical stabilizations that are needed.
So a parent,
absolutely.
A parent now thinks that their child may have something like this. They brought it to the attention of either their pediatrician, their family practice physician, their internal medicine physician. The internal medicine physician or family physician thinks that, yes, there is something happening. How does that person now respond to get them into a program such as yours?
Mm-hmm. I think they call the main number for the eating disorder program at Somerset, Robert Wood Johnson. And there starts a beginning educating for the family, significant others. There's an intake and an evaluation of the presenting signs and symptoms. There's a reaching out to the referring physician or therapist that's really sounding the alarm and concern about this individual. And then there's an intake that's scheduled for myself or the other co-medical director, Dr. Benor. And we do a comprehensive evaluation.
And that comprehensive would include both the therapist and the dietitian?
Initially, it is just Dr. Benor and myself doing a very comprehensive medical psychiatric evaluation for the eating disorder presentations and complaints. At that point, we determine a level of treatment recommendations, a treatment plan for that individual that responds to their individual needs and where they are along the trajectory for their eating disorder symptoms. And that could be an inpatient eating disorder admission, a referral for a partial hospitalization program and intervention, or an intensive outpatient, recommendation.
So I've now referred them, and now you're making that, we're going through the whole determination. What determines whether it's an inpatient or outpatient?
I think the severity of the presenting symptoms, the length of time, the chronicity of the illness, how debilitating that illness has become, how has it interrupted their daily functioning, their ability to succeed and do, their academic works, perform their work responsibilities, or engage in their lives and relationships. Basically, the bottom line is the debilitating, devastating interruption of a quality of life and their ability to function. Most importantly, an inpatient eating disorder recommendation will be because of those intensive interruptions of function, medical instabilities, and malnourishment. At that point, you need to break the cycle. You need to admit that individual for a very comprehensive inpatient medical, psychiatric, nutritional, therapeutic, comprehensive treatment approach to stabilize the presenting symptoms at that point in time. Leading the way will be a lot of the medical instability, malnourishment, the concomitant medical complications resulting from that. And what's very remarkable is how astonishing nutrition will kind of move in and really shift the course of that illness. Cognitively, cardiovascularly, nutritionally, mood-wise even. It's remarkable how significant nutritional restoration, balanced eating, and these comprehensive treatment interventions will really make a difference.
Well, that's what's so important about your unit, the inpatient unit that we have at Robert Wood Johnson.
Yes.
And again, the fact that there's only 2 in the state itself
is amazing.
Let us hear about this inpatient treatment center that's so different than others, or what makes it so remarkable.
Well, we'll get referrals from medical units, ERs, because there's an ability to stabilize dehydration, electrolyte imbalances, identify the problem. But even on medical units, they don't have a comprehensive team. They don't have a structure of treatment. They don't have specialists who work together as a team to stabilize some of the very complicated medical challenges involved with these eating disorder presentations: cardiovascular, sinus bradycardia, renal impairments, GI disturbances. These are concomitant medical challenges that even medical units are just not equipped to really bring together a comprehensive treatment approach. And that's where an inpatient medical unit like ours really does make a difference. And they're far and few between. And when you have someone who's seriously medically compromised, it does really make a difference. And it also brings along an opportunity to intervene for the family and the significant others in terms of education, support for these families. And that is a foundation for prevention and relapse prevention when the individual's ready to transition to a partial program, an IOP program, or their outpatient team, because that foundation of education and intervention is really important, not only for the individual, but for the significant support, family and loved ones that come along with them.
Again, the big difference in a medical unit is we don't have the psychologic intervention, we don't have the dietitian intervention that you would in an inpatient eating disorder program. You know, as a physician, you're seeing the patient, you're taking care of that acute problem, and you may add something on near the end of a social worker, or you may add the dietitian at the end. The whole idea of this is it's also working through the psychologic. Now, do you want to talk a little bit about some of that?
Yeah, absolutely. So eating disorders a lot of times can actually be an attempt to cope. And so to cope with difficult feelings, to use some of the symptoms or behaviors for emotion regulation. So one thing that we do is we really work with our patients to help them to develop healthier coping skills. So as the eating disorder behaviors are taken away, we are helping them to learn healthier strategies to regulate some of their emotions. And that can definitely be, I think, very important and helpful for them in this process.
So we're trying to take away from them their thought processes of that their body images are poor, giving them better images of what they really should be like and what society basically is looking for them to do.
Yeah, yeah. And looking beyond sort of underneath also, because it's not actually about food. It's not actually about their body. So a lot of times it's this low self-esteem that is being projected onto their body. So they are focused on needing to change their bodies. That's what they feel in control of. But we actually need to look a little bit deeper and help them feel better about the people they are.
And even more important is also the family.
Absolutely, absolutely. So bringing the families in, giving them education, and helping to improve communication also in the families is a really integral part of the work that we do as therapists on the unit.
And then, of course, the other thing is diet. You know, just giving them food is not the answer.
I am not their friend when they come in.
Although I do say all the time, their meal plan is their best buddy. You know, that's kind of reframing their association with food in a healthy, positive way.
Absolutely. So when they come in, food is the scapegoat. Food is to blame for, you know, all of the issues going on in their life. So what we work on is giving them lots of facts. Nutrition is based on science, and there's a lot of facts that go into that. So just giving them the education and the knowledge to understand what's going on in their body as they are using behaviors and also as they're feeding themselves. So for example, you know, initially when they come in, they're lightheaded, they're dizzy, you know, all these symptoms that Dr. Ospek was mentioning, you know, and then a couple of days after they're fed, I go back to them and say, well, how do you feel now? Like, what's the difference as to, you know, how are you feeling now as to when you first came in? And they're absolutely able to say, well, I can think, you know, they're a little bit less irritable. You know, when we first see them, they're like, you know, I don't want to do this. I'm not going to do, you know, any of this food, it's not healthy, or that kind of thing. But once you see the nutrition start to kick in, it's, you know, you really see the difference. And that's when they can start to work on the therapeutic and start the healing process.
So the other hard thing as a primary care physician is recognizing it before it gets serious.
Right.
It's that an eating disorder can lead to lots of other problems, such as anxiety, depression. And then we start treating the anxiety, depression without going to the underlying source of the problem.
Right. You know, there's a significant prevalence of anxiety and depression that accompanies these eating disorder. And without kind of treating the whole individual, you know, you're just missing a big part of the ability to stabilize and really make a difference and shift the focus of this unfolding illness. And so depression, anxiety is there. It gets very dicey and complicated with malnutrition. And so, in these comprehensive treatment settings, you're able to do the whole package, and you're able to kind of restore nutrition. You're able to kind of establish balanced eating patterns, and then evaluate carefully the still emerging signs and symptoms of depression and anxiety that might continue to linger there. And then there's an opportunity to move in, educate that individual as well as their family about the interventions for treatment for depression and anxiety that will complicate their ability to recover, their ability to actively engage in their treatment program, and certainly to prevent relapsing once they're really restored nutritionally and headed out to their outpatient teams, and then stumbling back into the behaviors and the symptoms. And so that's really, really important.
So there are going to be parents who are listening to this, and they've got a 15 or 16-year-old who's in high school, either a boy or a girl. If it's a boy, he's on the wrestling team, and they're always looking at the weights.
Yes.
If she's a girl, they're all concerned about the fact that she's overweight compared to her friends, and that she wants to be on the sports. What do you tell those parents to try to avoid them developing an eating disorder, and if there are signs or symptoms that they see, what they should be doing?
I think that there's a support for these young adults to really vest themselves in areas that they can build self-worth, confidence, self-assurance, that they're bright, intelligent, creative. But there's something that shifts when that kind of investment becomes mandating. And that's where parents need to really be more supportive and tuned in about balance for their children, where there's a pursuit of these involvements, but not a pursuit of perfectionism. High-risk competitiveness, where there's a drivenness about their behaviors, their need to succeed, that there's a reaction that if they get an A- or a B+, that the world falls apart for them. That the match that they were vested in and competing in begins to become an all or nothing, kind of challenge for their child. That's a warning signal. That's not balance. There's not resilience with that. There's not an opportunity to build self-worth, and just like Kelly was talking about, these eating disorders roll in and they begin to become mandates for their identity, their self-worth, their accomplishments. And then what they used as a springboard begins to get lost, and now it's just the pursuit of this perfectionism. Sometimes it's attached with thinness. Other times it's really kind of compulsively driven by control mandates, whether it be with their food, whether it be with their body image, whether it be with their exercise regimens or their competitive outlets or their academic challenges. Those are the warning signals that begin. And you begin to see this at home. Parents will begin to bring their children to their pediatrician because now they're worried. Home now is one minefield for food, mealtime, eating, and avoidant behaviors, anxiety, outbursts about control and loss of control. This is not something that is any more subtle. It's now ruling family dynamics, life, quality of life at home. And at that point, it's out of the gate. By the time they're really bringing it to their practitioners, it's already a problem, and it's evolved to where there's interventions that are needed.
And after someone's finished all of this, I'm sure we have follow-up afterwards.
Yes, in terms of after our
Inpatient,
treatment
they've gone to
program,
outpatient.
You know, we really then work with a referral base of individual practitioners in the community who do specialize, who are knowledgeable, have expertise in eating disorders, because I think that's really important to begin to have a team in place that will work with the individual and the family after discharge from these very intensive treatment programs. That is the cornerstone for relapse prevention, because a lot of these individuals will be lost to follow-up. You know, to try to put together a team out there in the community is really, really difficult. You know, very, very challenging. And you want a team that works together, that communicates together, that coordinates their treatment interventions for that individual and their family. And then we have those referral bases that we really set up and specifically coordinate their transfer of care when they leave our care to an outpatient team. You know, we bridge that liaison with the outpatient team. We're still their treatment team.
Thank you all for being here. And thank you very much for describing to us how important eating disorders are, and the psychologic, the dietary, and all of the medical things that can be involved in it. And thank you very much also for running the inpatient program at Robert Wood Johnson Somerset Hospital.
Thank you for having us.
Thank you.
This concludes our episode of Robert Wood Johnson University Hospital's Health Talk. Please remember that the opinions expressed here by our medical experts are not a substitute for medical advice from your physician. If you need a physician, please call our free physician referral number at 1-888-MD-RWJUH. For more information about our eating disorders program, please visit our website at www.rwjbh.org/Somerset. Thank you all for being here, and thank you for everything that you do for our patients.